Hello, everyone. My name is Dr. Gabriel Corral, a plastic and reconstructive surgeon, and today we're going to talk about vaginoplasty customization and postoperative care for patients who are coming to our center. First, we must start with you can only customize what you started with. Understanding the surgical outcomes are shaped by your own natural anatomy and the tissue that is available. In other words, depending on where you're starting the process and what is your current anatomy, the distribution of tissues in the body, is how we can customize and change certain aspects of vaginoplasty. Let's take a closer look about these factors. So this is a result from one of our patients, and I wanted to highlight essentially five factors that can be customizable: clitoral size, labia majora and labia minora, vaginal depth and width, and urethral positioning. Let's take each step and understand how this is created. The clitoral size is created by reshaping the glands of the penis. This can be created a larger or smaller size when designing the clitoris in the first place. Of course, if you decide to go too small, you are decreasing the square centimeters of available surface that has sensibility and has the receptors to provide that sensation. And if you go really small, you can also jeopardize the blood supply of the clitoris. So it is important to understand you can always, if you make it slightly larger, you can always come back and have a supervision to reduce the size if that's what you desire. If you have something in mind, you can also start with what you have in mind as well in terms of sizes. Labia majora. Labia majora prominence or fullness is something that many patients request. This is created by using and shaping the fat that is around the testicular cord and the testicles. If there is a significant amount of fat in that area, well, then you can preserve it or reduce it to achieve the desired result that the patient is asking. But if you're on the other side of the spectrum, in which the patient is very thin and does not have enough of this tissue to form prominent labia majora, then it cannot be created at the same time. You perhaps have a flatter result that you need to understand and accept. And if you are thinking about options in order to increase the fullness, you can perform a small fat grafting to add fat to that area. Now, generally, the thing you have to think about if that's something that sounds appealing is where are we going to get the fat from in the first place? Do you have enough reserves of fat in another area to provide that? So those are the things to think about if you're on the side of the spectrum. Labia minora is a more complex topic. Labia minora can be also created using the skin that is adjacent to the head of the penis. As you know, circumcision's variability is very, very different between patient to patient. If you don't have a circumcision, then this skin is available and there's no scar in that area. So the creation of a labia minora using that skin is very favorable. It is possible. You can see this patient on the picture who the tissue is different. It looks a little bit pink or has different, a little bit of different texture than the surrounding penile skin. This is a very nice way to create long-terming, long-lasting definition of the labia minora. If circumcision has been created and is very close to the head of the penis, then that scar limits the ability to use that tissue. Sometimes you're still able to use a small amount of the tissue to create a clitoral hood, for example. But if it's all removed, then that may not be an option. So you rely a lot in more of the quilting sutures. You can see these areas of indentation that create the separation between the labia majora and the labia minora. These areas are called the interlabial sulcus, can be created using more of a quilting technique. And that is another way to create labia minora. However, over time, there can be effacement. These areas can be less defined over time, and they may require further revisions to make this stand out a little bit better. But in general, you want to try to achieve the reconstruction of the labia minora using that tissue as it will provide a better result long term. Now, vaginal depth and width is something that can be customizable to a greater extent. The reason is if you're trying to achieve a vaginal depth that is between 5 to 6, 6.5, I think that is something that is realistically possible. Now, other sizes, other requests, 10 to 12 inches or so are much more difficult to create and sometimes not possible as there's not enough space in the pelvis and the abdomen to create this greater depths. The other thing to consider is your pelvic width. The pelvic anatomy is very different. The biologic male and the female pelvises are different to begin with. In general, if the pelvis is really narrow, then there is a limitation of how much you can open the pelvic canal in order to accommodate a larger dilator. If you're a smaller individual, perhaps there is a pelvis that is really narrow from a bony standpoint, then you can open the pelvis up to the level of those muscles, and you may have a limitation in order to accommodate a large dilator, for example. So again, understanding your anatomy, understanding where are you starting in the process will help you understand what can your potential outcome be from an aesthetic point of view. And lastly, the urethral positioning is something that can also be customizable. This generally is going to be between 3 and 5 centimeters from the clitoris. And you can see in this picture, the clitoris is here, and they're approximately 3 to 4 centimeters. The urethral catheter is placed. You want to have some separation to create the pink part of the vaginal vestibule, and that's usually created with the urethra as well. This is another patient who has a little bit more of that peritesticular fat that we were talking about. It would allow for preservation of the tissue in order to create a little bit of a fuller result. Now, if you look closely in this patient, the labia minora using the penile skin tissue or the prepucial skin is located right here. And this patient had a circumcision, which allowed to use some of the tissue, but not be able to extend it all the way down like the other picture because of that present circumcision. Now, the same interlabial sulcus was created using those sutures, which allow you to shape a labia minora, but the tissue has a change between the superior and inferior aspect of the vagina. Now, some of the requests and considerations that we see is that most patients will want an aesthetic, symmetric, and natural result, as close as it can resemble a cis female anatomy. Everybody wants to have a functional vagina with adequate depth, capable of having sexual activity. And most patients want to preserve clitoral sensation and have the ability to orgasm. Those are mainly the main goals of a vaginoplasty surgery. Now, some of the drawbacks of the surgery and things to consider is, for example, the fullness that patients may have at the level of the mons, directly above the clitoris, especially in thinner patients. If you have more prominent labia minora, this may increase the friction or discomfort with underwear. So you have to stay within sometimes regular limits. This patient had labia minora reconstruction, desired to have a little bit of a larger clitoral size, which should left that way. And you can see the pink inside of the vaginal canal from an intestinal mucosa used to reconstruct the vaginal canal. Again, larger clitoris may also lead to hypersensitivity. So you need to advise patients that you may be a little bit more sensitive. They may rub against clothing, and this sensitivity can be sometimes be annoying. It's not a very pleasurable experience. But again, this can be revised later if the patient desires to do so. And then if there is an excessive depth, this may increase the risk of prolapse or stenosis. For example, if patients have increased depth, they may not be able to dilate fully with regular convention dilators, and the part that is not being dilated may continue to contract. If there are larger proportions of skin graft or intestinal tissue to create a vaginal canal for a vaginal canal that is greater than 5 to 6 inches, then this can be led to prolapse, as the tissue may not heal and start prolapsing after the surgery. This is another patient where you can see here it's just healed afterwards. The labia minora has now completely relaxed. The clitoris is a little bit more visible, but it's noticeable as well. Limitations and some ethical considerations. So things that we generally try to avoid during the procedure. If patients may request an unrealistic anatomical modification that we feel that may affect their ability to have a functional and aesthetically pleasing result. Some patients may require over 10 inches of vaginal canal depth for an intestinal vaginoplasty procedure, and this is very difficult. This is associated with other risks, such as increased mucus hypersecretion and a significant increase of recurrent prolapses. So patients may require an excessive amount of reduction of the clitoris. If we feel that this reduction is too excessive, that it may compromise the blood flow and the sensation, that's something that we would not agree to proceed, of course. And then anything that will cause a long-term health risk beyond the surgical standard of care for patients seeking this type of procedures. Patients may have different requests that we may feel like may not have a significant impact within the first couple of weeks after surgery, but 5 to 10 years later, those implications may play a more important role. So all these things should be discussed with the patients and make sure you have an honest approach and make sure that you communicate what your goals are so we as surgeons can meet those expectations, make sure that they're anatomically real and that we can perform and achieve those fine details that you may be looking for. So some patients ask, what is the default surgical approach? Many patients are excited. They want to make sure that they have a good result, and they want to make sure that we just do a good job. So what do we go for? So if there's no specific request, I try to achieve at least 5 to 6 inches of vaginal canal depth. I try to create some level of proportion depending on where we are starting with the patient. If the patient is a thinner body habitus, we want to make sure we have proportional labia majora, a thinner labia minora, so it looks congruent. If the patient perhaps have a little bit more tissue, they have anatomy that is a little bit more lax, well, then I want to make sure that that labia majora matches the external appearance of the patient, so it's all flows and it looks good postoperatively. If the patient perhaps has a little bit more redundant tissue and there's more greater labia majora, well, that patient may require a little bit of a taller clitoris or a fuller clitoris to be able to identify that after surgery and make sure that it can be easily found during their postoperative recovery and after surgery as well. We want to make sure that the clitoral hood is preserved and that it is formed to decrease hypersensitivity to the area. And we want to make sure there's a good distance and a safe anatomical distance between the urethral meatus and the clitoris. The urethral meatus, if it's too close to the clitoris, that can be a problem with hypersensitivity and hygiene issues. If it's too low inside the vaginal canal, patients may feel that they can develop recurrent UTIs, or when they urinate, it can go a little bit into the vaginal canal as well. So we want to make sure it's in the correct location. So what are our vaginal dilation recommendations? And this is, of course, exclusively to patients who are going to our center seeking this procedure. Your surgeons may have different approaches and way they do this. But for patients who are undergoing a penile inversion or PPT or peritoneal vaginoplasty, during the first 3 months post-surgery, we ask patients to dilate 3 times a day for 20 to 25 minutes. If the patient has had an intestinal vaginoplasty, then you do one less dilation, which will be twice a day for 20 to 25 minutes. Now, 3 to 6 months after surgery, for a peritoneal or penile inversion vaginoplasty, you can continue doing from 3 to 2 times a day for 20 to 25 minutes. If you have been cleared to have penetrative intercourse, this counts as one dilation, of course. And for intestinal patients, generally we recommend to continue twice a day until that 6-month mark. What about 6 months to 1 year? For peritoneal and penile inversion, you can decrease to once a day, 20 to 25 minutes per session. And for intestinal vaginoplasty, you're going to be doing dilation only once a day, depending on your progress and the amount of intercourse that you may be having. Now, what happens after the first year? Well, the first year after surgery, you can still develop vaginal stenosis regardless of the method of vaginoplasty that you had. So you have to be a little bit cautious of how you approach it. There are no long-term studies looking at what are the best dilation protocols for the first, after the first year for surgery. So our recommendation is for patients to start decreasing by going to every other day of dilation for the first few weeks. And generally for the first 1 to 3 months, they should continue for every other day or perhaps 2 to 3 times a week, depending on their intercourse and depending on how busy patients are. And continue with some level of regularity until you are sure that things remain stable. Once things remain stable, you're able to achieve the same dilator color, the same depth, with the same amount of timing, with least amount of resistance, then you can decrease your dilation to perhaps once or twice a week, and then progressively go down to doing the same thing every other week until you are decreasing your dilation. For most patients, you still have to dilate at least once a week, and transition that to at least once or twice a month or so. But that process may take 2 years to make sure that you feel confident that you're not going to have any regression of the tissues or difficulty with dilation. What about post-surgical hygiene and wound care? So for our patients, we recommend for patients to shower and clean the incisions with any type of soap and water on a daily basis. Applying antibiotic ointment, we like to use hydrogel with silver, and this can be applied over all the incisions. Now, the key is to apply this at least 2 or 3 times a day only, and very thin amount will go a long way. If there is too much moisture in the area, that may negatively impact the outcome. So remain using antibiotic ointment, but use a small amount, only 2 or 3 times a day. Another option is to purchase an antiseptic called Vash. This can be purchased through Amazon and is a great antiseptic that you can use to clean all your incisions. You can also use the Vash to saturate the moist gauze that will be placed at the entrance of the vaginal canal as you're going through the first 3 months of your healing process. And it's a great thing to keep to wash any wounds as you go through the healing process or if you go through other procedures. The moist gauze should be packed very gently at the entrance of the vaginal canal. This allows you to undergo wet to dry dressing changes for any areas of wound separation. If there are no wound separation areas, especially during the first 3 months, then there's no need to use a moist gauze. The hydrogel with silver with an ABD pad should suffice. What about pelvic therapy? Pelvic therapy is super important after vaginoplasty, and we can discuss this over a length amount of time. But pelvic therapy usually begins at 3 to 4 weeks post-surgery. You need to make sure that you attend at least one session per month for the first year. After surgery, you are okay to do your own regular natural movements the first 12 weeks. And after 12 weeks, then you can start more on aerobic exercise, walking more than a mile, doing a treadmill. It is allowed to have normal movements, light activity at home. Perhaps you want to do stairs at home to go from one room to the other. That is all fine during the first 12 weeks. What you want to try to avoid is any type of continuous stretching, regular aerobic exercises, or walking more than 1 mile during the initial recovery of time. After your 12 weeks of recovery, you can proceed depending on how we discuss and how your healing is going. Then we'll allow you to start more strenuous exercises or going back to the gym or immersion in water and so forth. So we will have to have a discussion about your progress because everyone's progress is slightly different and see what are your current status of your wound before we let everything start stretching and doing other type of exercises. Another common question is vaginal douching. What are our recommendations? So in general, for the first 2 months of your recovery process, you're going to have to do a vaginal douche. And we will go over this before you leave the hospital to ensure that you understand that the douching will be performed usually twice a day during your first dilation and at the time of your last dilation. You can use normal saline, you can use distilled water, but those two items can be quite expensive. You can also use tap water if you're not on well. If you are unwell, it is okay to use tap water, but you have to treat it first, unless you have had the well water examined for bacterial counts. And sometimes, even though you're on well water, it's very drinkable, and that will be okay to use for your vaginal douching. If you have well and you have not tested, you don't know the level of bacteria, then it's best to just get tap water and treat it by allowing it to boil and cool down. And you can reserve this and do this before surgery so you have enough water to do your vaginal douching. From the month 2 to 6, if you're still having discharge, we recommend you continue in douching 1 to 2 times a day. If you have no discharge, you can start reducing this once a day, or you can go back to every other day. But in general, for most patients, you will need to do a once a day dilation, which will be important. And this is for peritoneal and penile inversion vaginal. And from month 6 to 12, you can continue to douche once a day from month 6 to month 12. If you're experiencing intermittent drainage, then you may need to continue doing that daily douching. And for intestinal vaginoplasty, those patients will need to require daily douchings for at least for the first year. And it may require to be at least every other day for the rest of the life because the amount of lubrication and mucus production may vary over time, and you may still need to do that to control the odor and control any drainage. So these are some of the options. You can use Summer's Eve, extra cleaning vinegar and water. This is completely okay to use, especially if you are past the 3 month mark. Another option is the V Gentle option, which can be purchased online as well, or V Fresh. This can also, it's a great product that have a small amount of apple cider vinegar, so you can control a little bit of that odor and keep everything fresh for your postoperative recovery. And a fleet enema I put here, which is okay to use for patients who are having an intestinal vaginoplasty. Of course, this is very safe in the colonic mucosa. So if patients want to use a fleet enema, you can use this at least once a week and use it in the vaginal canal to clean the intestinal vaginal canal conduit only. The other two products are for penile inversion and peritoneal vaginoplasty, which generally can be okay to use, especially after the first 12 weeks of your recovery process. So what about after 12 months? Many patients ask, well, I am decreasing my dilations, I'm very happy, but what about the douching? It's really difficult to douche, on a daily basis. At that point, if you have had a penile inversion of peritoneal, you can decrease your douching to 2 to 4 times a day per week. It is okay to use the products that we mentioned before, the Summer's Eve extra cleaning, vinegar and water, and the Be Fresh, Be Gentle Sensitive ACV. For intestinal vaginoplasty, fleet enema or tap water with a little bit of soap continues to be a great solution to reduce the mucus. Oral probiotics can be very helpful in order to help with odor and drainage, especially for those intestinal vaginoplasty patients. I included an option that my patients like called the Euro, and this can also be purchased online or at Amazon. So, depending on your ongoing needs and adjustments, douching should continue indefinitely as the needs change for each patient over time. These changes are created by different things that happen throughout the process. You may have some hormonal changes, sexual activity, the anatomy of the patient. You may notice that even though you are a year out, you started having some drainage after not having so much drainage. So then you have to continue incorporating, perhaps increase the amount of douching until you see a reduction, and then you can decrease back down. So this is something that is fluid. It will continue to change as you go through the process until you really get to know your body and what's going to do that, which happen at least after 2 years. After 2 years, if you are doing well and there's no discharge and you're happy how things are going, then you may need to reduce it to maybe once a month or twice a month. The big question through this process is, at what point do I stop introducing any type of solutions into my body and allow some of the flora to grow and the anatomy and the cells continue to change. And I think important to know that in the first year, it is common to need a little extra help to decrease the bacterial load and to allow things to normalize. I think after the first year, you can continue to decrease the amount of solutions that you're using and allow your own body and your own cells to continue to change. There are no long-term studies to know exactly when is a good time and what time does that cellular change occurs inside the vaginal canal yet. But we can tell if we have been doing this for a long time, there are changes that happen to that skin if skin was used over time that definitely make the vaginal canal much more softer and allows for a natural appearance of the vaginal canal. In the cases where skin have been used, peritoneum looks quite biologic from the get-go as the area heals, and the intestinal mucosa as well for those patients who are seeking intestinal vaginoplasty. So again, I think it's important to maintain the support of vaginal douching during the first year. After that year, you can certainly decrease the amount. Now, you want to try to avoid using other solutions without consulting us. I have had patients who have used coconut oil, I have some patients use Monistat or silicone lubricant, and those are other indications to use. And you want to make sure that we discuss that before exploring other things that are not water soluble, other products that we discussed below. Also, for silver nitrate and other medications, this should only be used after a discussion with your surgeon, and this should only be performed traditionally in the medical office where we can actually treat those areas. If you have had specific indications to treat an area with silver nitrate, make sure that you discuss with your provider what are the steps in general. When we're treating an area with silver nitrate, we treat the area. Then we want to make sure you use a moist gauze to protect that area from getting silver nitrate anywhere else until that area has healed or dry up, and then you can continue with your day. So that's something to keep in mind to avoid getting silver nitrate in other regions of the area. Apply it locally, put a little moist gauze over that region, and then you can put a pad and continue with your day. Don't leave it uncovered. Some final thoughts: empowerment through customization and care. Customization allows for a patient-centered approach. Hopefully, after our discussion today, you have a little better understanding on some of those points that you can discuss with your surgeon that can be customizable and some of the limitations that may not be able to be customizable. Post-op care ensures long-term function and satisfaction. You have to really dedicate yourself at first, not only to perform the dilations, but understand the entire process of a vaginoplasty reconstruction, which means understanding the impact of the pelvic floor, understanding pain control, understanding the importance of dilation and douching. And time is our friend. Over time, a lot of the things will tend to get better, and you hopefully will be happy with the process of your surgery selection. If you have any questions and you're a patient of mine, you can send any questions through the patient portal. I included the phone number below, 410-772-6500, or you can email us to the gender.affirmation@medstar.net email, of course. With that, I want to thank everybody for watching this video. Hopefully this shine a little bit light on customization and postoperative care for patients who are seeking vaginoplasty. Take care.